Hi, everybody, and welcome to part 3 of our 10-part GI lecture series, designed for those of you studying for USMLE Step 1 or COMLEX Level 1. Today, I'm going to be talking about the esophagus. And again, like most sections, I'm going to start with anatomy, then move on to physiology, and we'll finish it off with clinical conditions. So starting with anatomy, I think it's a good idea with the esophagus especially to start with some histology. The reason why I think that's a good idea is that, as we talked about in the GI intro lecture, most of the GI tract is formed from the embryonic GI tract, and with that comes its own cell types. With that said, the embryonic GI tract doesn't begin until the very end of the esophagus. So, for most of the esophagus, it's actually composed of a different cell type. It has a different arterial blood supply, and that can present with different clinical conditions like different cancer types. And right here is another reminder from our GI intro lecture that not only the upper end of the esophagus, but also our oral cavity and the very end of our anal canal, the lower half of it, is all technically not part of the embryonic GI tract. So it has different cell types composed in that region. And that cell type is referred to as non-keratinized stratified squamous epithelia. And so I'm going to break this phrase down so we know exactly what that means. So we saw epithelia in our oral cavity lecture. Epithelial cells are just cells that line glands. They could line organs, they could line our skin. So it's a pretty broad term. And it's densely packed, way more densely packed than connective tissue. And you can see there's different types of epithelia. And I'll show you a picture. We have two different types of epithelia. And in both examples, you can see how tightly packed these cells are compared to the connective tissue that exists right behind it. Now, when we refer to whether something's keratinized or non-keratinized, that's usually to refer to squamous epithelium, and I'll show you what I mean. So keratin is a waterproof protective protein that exists on our hair, our skin, and our nails. And if you're non-keratinized, that means you don't produce keratin. So why do they have this distinction in this phrase when it comes to esophageal epithelium? The reason they do that is because there's a different type of stratified squamous epithelium that exists in our skin that is keratinized. And let me show you a picture. So in our skin, we have this thick layer of keratin here. And again, that's a waterproof layer. But in the esophagus, and then you can see on the left side here, you can still see the stratified squamous cells below this thick layer of keratin. Whereas on the right, if we look at a picture of our esophagus, we still have this layer of squamous cells, but we don't have that layer of keratin. That's why it's called non-keratinized. And the last thing, which I kind of alluded to a moment ago, is stratified. So cell types can be simple or stratified. Simple just means there's one layer, and stratified means there's many layers. And so if we go back here, you could see how many layers of squamous cells are just packed on top of each other, going all the way through. You can see probably 24 layers of cells right here. And then the last thing I just want to clarify is what it actually means to be a squamous cell. What does that look like under a microscope? Well, we've been looking at some of these cells and they have this fish scale appearance, which is pretty classic. On the left, we have columnar cells. They don't really look like fish cells. They look like columns, so they're aptly named. But these guys over here on the right are squamous cells. They look like fish scales, excuse me. And you can see that in our upper part of our esophagus, you're going to have more of these types of cells. And in our lower part of our esophagus, you're going to have more columnar epithelia. And so, and the relevance of this, like I just alluded to, is that when we look at our embryonic GI tract that starts at the very end of our esophagus, you're going to see columnar epithelia. But there are circumstances, which we'll talk about later, where our squamous epithelia can actually convert into a columnar epithelium due to repeated damage to the tissue. And that may not be dangerous, but that columnar cells that have already changed from a different cell type, those could morph even more into a cancer. So that's always something we have to watch out for. Now let's talk about a few relevant features of the esophagus. It's just a hollow tube, so there's not too much to talk about. When we discuss motor control, I just wanted you to know that the upper 1/3 of your esophagus is composed of striated muscle, and what that means is that you can voluntarily control it, kind of like when you're taking a bite, you can feel the upper part of your throat being able to control that swallow reflex. But then as the food passes down the esophagus, you lose control, and that's because the lower 2/3 of your esophagus is composed of smooth muscle. I think this is a good part to talk about the diaphragm, since the esophagus does pierce the diaphragm, and they do like to test which structures pierce the diaphragm. So let's just go over that really quickly. The esophagus pierces the diaphragm at the level of T10. And so if this is our diaphragm here, and then I just wanted to refer to some other structures that pierce the diaphragm too, including their spinal level. And I'll just give you a mnemonic that I've always remembered. I don't know how useful it might be to you, but whenever it comes to anatomical structures and stuff, I do find it a little easier to remember it through mnemonics since there's often not a clinical correlate to help you out. So the IVC pierces the diaphragm at the level of T8. The esophagus and the vagus nerve pierce the diaphragm at the level of T10. And then three structures pierce the diaphragm at the level of T12. That's the azygous vein, aorta, and thoracic duct. And so I've always used this mnemonic, that I made up. It just goes I8, 10 EVs at 12. So EV is a Pokemon. It's kind of a sad mnemonic now that I think about it, but it is what it is. And so I think of the 8 for the IVC is the 8 for I8. And then 10 EVs is T10, which refers to the esophagus and the vagus nerve. And then for T12, I think of the azygous vein, aorta, and thoracic duct. I don't know if that'll help you, but that's just kind of how I remember the structures that pierce the diaphragm. And the only other relevant anatomical structure that I wanted to go over is the lower esophageal sphincter. Now, this is the sphincter that subdivides our esophagus and our stomach, and it can protect against the reflux of gastric acid into the esophagus. So it plays a really important role. And if we look at here, if you think of gastric acid coming on through to the esophagus, fortunately, we usually have a lower esophageal sphincter that can protect us from that process. Now let's briefly talk about vasculature for the esophagus. The esophagus, you can divide their arterial supply into thirds. So we have an upper third, a middle third, and a lower third. The upper third receives branches off of the inferior thyroid artery. The middle third receives branches directly off of the aorta. And the important one to know is that the lower third of the esophagus can receive branches from the left gastric artery. And why this is important is because the left gastric artery arises from the celiac trunk, which is considered part of our foregut. Anything with the blood supply from the celiac trunk, SMA, or IMA are considered part of our embryonic GI tract. And so this is why the lower esophagus is considered part of the foregut. And I can show you that right here. We have our celiac trunk located right here. And you can see there's 3 different branches right here. And if I show you the left gastric, so this left gastric can come off, and esophageal branches of that left gastric can provide some blood supply to the very last half or the lower third of the esophagus. And there's one clinical correlate that's good to know. I'm going to hammer this home in a few different lectures, including the liver lecture, is that the esophagus drains into both the systemic and the portal circulation because it's part of the GI tract and it's also not part of the GI tract. So for the systemic circulation, you get lower esophageal veins that can drain into the azygous vein, and that can drain into our IVC, which is kind of our main vein that funnels fluids back to the heart. But at the same time, we have some of our esophageal capillaries drain into left gastric veins, which then drain into the portal system. So that goes portal vein, liver, hepatic vein, and then finally to the IVC. And why this is important? This is important because these 2 types of veins, the esophageal and the left gastric veins, can connect at times. Okay, and if there is a backup or a buildup of pressure in one of these veins, it can actually push into the other. So I'll show you what that looks like. Basically, here's what we just talked about. We had our lower esophageal veins that were going into the azygous vein and ultimately into the IVC. Whereas here we had our, left gastric vein that can go into the portal vein, and then it goes to the liver, hepatic vein, and ultimately ends up in the same place. Well, these two, if this gets bigger, if our portal vein gets really big, because of the connection between the portal system and our regular circulation, this vein might get enlarged as well. And if you look here, this is taken from the liver lecture talking about a few different areas in our body where our portal system and our systemic system have connections. You can see here we have esophageal varices is what I'm about to talk about with our left gastric and our esophageal veins. So what does that look like? What that looks like is if we do have a buildup of fluid in our portal system, let's say our liver is not working as well as we'd like it to, sometimes fluid can back up, it'll back up in our portal system. And because of this connection between our portal vein and our esophageal vein right here, it could actually back up and start pushing into this esophageal vein. The problem with that is that these veins here were not built to handle these kinds of pressures, right? So you can actually get upper GI bleeding, and it could be life-threatening upper GI bleeding in some circumstances because of this connection. And you can see a esophageal varix on the right here. You could actually see a few of them, but I'll point out one right here. So that's always something to keep in mind. Now we'll talk a little bit about physiology. And the big thing that you need to know physiologically is how the lower esophageal sphincter works, because there's going to be a few conditions that come up later on when we talk about conditions like achalasia, especially, that are dependent on the physiology of the lower esophageal sphincter. So as we talked about before, this is located between the lower esophagus, and the cardia of the stomach. It protects us against the reflux of gastric acid into the esophagus. And this relaxation is mediated by nitric oxide and a VIP. Okay, so two different compounds that help mediate the relaxation or opening of the sphincter. And both of these, the myenteric plexus can regulate the tone by using these. So I'll show you what that looks like. We have our stomach here, and we have our lower esophageal sphincter. Myenteric plexus neurons can release some of these compounds, and these compounds can act on the lower esophageal sphincter, and it can relax it and open it up. And we're going to find out later that you can have abnormal tone in things like achalasia, even things like GERD. It's actually for the opposite reason, but you can have a few different problems with your lower esophageal sphincter that can cause problems. Okay, now let's talk about conditions. And I've tried to subdivide it into relevant categories to make you lump things together more easily. We're going to start with upper esophageal conditions. And then I'm going to talk about a few conditions that are associated with hematemesis, or vomiting of blood. I'm then going to talk about that lower esophageal sphincter that we just mentioned, and a couple motility conditions, which are kind of similar. Then we're going to talk about probably the most high yield subsection. It's this pathway of GERD, Barrett's esophagus, and adenocarcinoma. And then I'll finish it off with a few types of esophagitis, which is just inflammation of the esophagus. So let's start with the upper esophageal conditions. There's a few you need to know. And we're going to start with the esophageal web and Plummer-Vinson syndrome. So an esophageal web, all that is a protrusion of the esophageal mucosa into the lumen. So that just looks like if this is our esophagus, we have a little bit of tissue that's sticking out into the esophagus, okay? And how this will present, you might get dysphagia of poorly chewed food. They'll have to specify that for you to start to think about this. And that makes sense, right? If you're able to chew your food well and you have little tiny fragments, that can pass easily. But if you don't chew well, then you might have a big bolus of food that gets stuck on that web. And the complications of this, there's a few different things. And the one I'm going to kind of hammer home for a few of these conditions is that if you have constant irritation, your risk of squamous cell carcinoma will increase. Remember, we're still in the upper esophagus, which is part of our non-keratinized stratified squamous epithelia. So if you're going to get inflammation to that tissue, you're likely to get squamous cell carcinoma as a result, and this inflammation can cause that. Here's an esophageal web you can see right there. I've tried to highlight it. And we'll move on to Plummer-Vinson syndrome, because this actually is a syndrome that has esophageal webs as one of its classic symptoms. So we don't know everything about Plummer-Vinson syndrome, but it seems like it has to do with nutritional deficiencies, and there might be some autoimmune component to it as well. And how this presents is that they'll always give you this classic triad on tests. The first one will be esophageal webs, as we've just discussed. You'll also get dysphagia, which makes sense. You'll have trouble swallowing because of the esophageal web. And then you'll get iron deficiency anemia, and you'll also sometimes get glossitis. I don't want you to forget that one, but the classic triad is the webs, the dysphagia, and the iron deficiency anemia. Now, those seem random, and so how I want you to think about this is I want you to think of Plummer-Vinson syndrome as a very severe nutritional deficiency, and I'll explain what I mean. So obviously, one of the three components of the triad is iron deficiency anemia, so it makes sense. You're already iron deficient, and there's some evidence that the formation of esophageal webs, at least some of them, are actually formed because of as a byproduct of iron deficiency. You get this mucositis, that's inflammation of that area, and it can form a web. And that all might be related to a nutritional deficiency in the first place. And we've talked about this in the oral cavity section, but glossitis, or inflammation of the tongue, is often due to either iron deficiency or B vitamin deficiency. And this is actually from our oral cavity lecture. I discussed right here that iron deficiency, B12, B3, B6, B9, B1, I don't want to forget about that. All those deficiencies can cause glossitis in some way. So it kind of makes sense that all these things, even though they seem kind of random from each other, they actually are combined by this nutritional deficiency. And now treatment for this, it should make sense. If we have a nutritional deficiency, how do you think we should treat it? We should give them the nutrients they need, and that's usually iron. And complications of this, we already discussed this, but anytime you have an esophageal web or any sort of chronic irritation to the esophagus or any part, I want you to think for throughout the GI tract as we talk about these things, anytime you get chronic inflammation or chronic irritation, that's almost always going to increase your risk of having some sort of cancer down the road. So now let's move on to Zenker's Diverticulum. So this is a lower pharyngeal or upper esophageal outpouching of the mucosa, and it's caused by a defect between the thyropharyngeus and the cricopharyngeus muscles in Killian's triangle. I know that seems really low yield, but I gotta tell you, they love to test this stuff. So just keep this in mind. So on your left, you can see this outpouching that I talked about. That's a diverticulum. And now on the right, I'm going to show you exactly where they like you to know. So they want you to know each of these muscles, and they want you to know Killian's triangle. So here's our thyropharyngeus in blue. Below that, we have our cricopharyngeus. And then in between those two, you have something called Killian's triangle. And sometimes if there's a defect there, a little bit of a weakness, you can actually get the tissue to push right through there. And you can see the diverticulum on the outside there. And how this will present, it's usually somebody who's very old. They're going to have trouble swallowing, and they're going to have really, really bad breath. I've never seen a question on Zenker's diverticulum where they didn't mention halitosis. And that kind of makes sense, that food's getting stuck in that diverticulum instead of going all the way down to our stomach, and that food can start to spoil in that specific area. And you could also get a sensation of food stuck in the throat. That's also seen a lot on tests. And also vomiting of undigested food for the same reasons we just talked about. I think halitosis of these three is really important, but I got to be honest, I've seen each of these on test questions pretty often. And they do like you to know if it's a true or a false diverticulum. And let me talk about what that means. How I remember this is a false one is that the Z in Zenker's, I think of Zenker's for falls to remind me. We're going to see this in a few different lectures, so it's good to kind of go over what a true diverticulum is and a false diverticulum. From our GI intro series, we talked about the different layers of the GI tract. We have our lumen, our mucosa, our submucosa, our muscular layer, and then we have either the serosa or the adventitia, depending on where you're at. And then in this case, I just wanted to go over what the difference is between these. So in a true diverticulum, the outpouching involves all four layers of the GI tract. So what that would look like, or actually, let me put these on the board first. A false diverticulum does not involve the muscular layer. Okay, so now let's talk about the difference between it. So in a true diverticulum, all 4 layers are involved. And so what that's going to look like, the outpouching will still contain every layer. Whereas in the false diverticulum, because the outpouching is actually breaking through a weakness in our third layer, this layer right here, it's actually going to break through this layer. And let me show you that right now. It breaks through this layer, and we don't have that as part of this diverticulum. So it's a false diverticulum because all 4 layers aren't included. And something I wanted to point out with true diverticula, you can see that our appendix is a true diverticulum. And later on, when we talk in either the small intestine or colon, we're going to talk about Meckel's diverticulum, which is also a true diverticulum. And the false diverticulum, as you can see, this layer is not included in it. That's going to be seen in Zenker's diverticulum right now, as well as diverticulosis, which we'll talk about in the colon section. Let's talk a little bit about esophageal stricture. It's pretty straightforward. It just means a stricture is just a narrowing. So this is an abnormal narrowing of the esophagus. And this usually happens because of chronic inflammation that leads to scarring and stricture. So if I draw our esophagus here, if you imagine there's some inflammation, sometimes our body can just handle, most of the time actually, our body can handle that inflammation and recover properly. And then you don't have any problems, you're good to go. The problem is, especially in the setting of chronic inflammation, sometimes you'll have inflammation and then that'll turn into fibrosis and scarring. And sometimes that scarring has contractile tissue that can actually bring the tissues together, and you'll get these strictures, these narrowings. And we'll see this in a few different diseases like Crohn's disease as well, primary sclerosing cholangitis. It's the same idea where you just have this chronic inflammation that ends up kind of causing this fibrotic tissue that brings stuff together. And so this is caused by inflammation. That's the main cause. So esophagitis. And of the forms of esophagitis that we'll talk about later, acid reflux is the most common cause. You can also get it through something called caustic ingestion, of lye. And I want to talk a little bit about this. I don't remember this being tested in step 1, but it is step 2 fodder, so it's useful to know. So anything that's caustic just means it can corrode organic tissue. So it's really, really dangerous to ingest this. And usually it's ingested during a suicide attempt that's incomplete. And the complications of this is that because you have this inflammation and these strictures and this really, really dangerous substance, it could actually lead to strictures as well as squamous cell carcinoma. And what they like to do on tests, they like to trick students who know the association between lye ingestion and squamous cell carcinoma and give them a trick question. And I'll show you what that means. If you ingested lye, it's not like you're going to get cancer overnight. You're not going to get cancer even 6 months or a year later. It takes around 40 years on average from when you ingested lye till when that squamous cell carcinoma develops. So on tests, they might give you, hey, this person ingested lye. 6 months later, they're coming back. What's wrong with them? And they'll put squamous cell carcinoma as an option, but it's way too soon for that to develop. If that's the test question, the answer is going to be esophageal stricture because that can happen pretty quickly. So we've talked about some of the risk factors for squamous cell carcinoma already. We've talked about esophageal web, esophageal stricture, anything with chronic inflammation, lye ingestion, anything that's caused irritation or inflammation in the past can cause squamous cell carcinoma. So let's go over that. Obviously, that's a cancer of the squamous cell epithelia that we've been talking about. This right here. I'm not going to bug you guys with all this again. So if this all gets, gains mutations over time, it can cause cancer. It's the most common esophageal cancer worldwide, but only the second most common in the US. So adenocarcinoma is more common in the US. And it usually happens on the upper 2/3 of the esophagus, which again makes sense because our lower 1/3 of our esophagus is normally it's usually a big portion of that's already simple columnar epithelia, or it has transitioned to simple columnar epithelia through the process of metaplasia. And so what causes this? Chronic irritation. I don't know how many times I have to say that, but I really want to drive that point home. That could be irritation through tobacco, through alcohol, hot liquids. That's one of the reasons why it's more common worldwide as well. And caustic ingestion. But remember, there's a really, really long time difference between when you ingest it and you actually get it. And then there's quite a few conditions that can irritate your esophagus that can cause it. We've already talked about the webs, we've talked about Zenkers, achalasias here, which we'll talk about later, that can also cause chronic inflammation of that area. And as with most cancers, you're going to get weight loss. This is really important, this progressive dysphagia. Because the cancer is slowly growing through the lumen, you're going to have solids affected first, and then liquids eventually as the cancer takes over more of the lumen. Odynophagia, it's probably going to hurt to swallow, especially if the cancer is invading into local nerves. You can get hoarseness for that same reason. And on histology, they do like you to know this. For any squamous cell carcinoma, you need to know that there are malignant nests as well as keratin pearls, okay? So this picture is great because it has both of them in there. I can show you the malignant nests here on the left. You can see how they look angrier than normal, but they're actually pretty structured. There's like a nice nest of these cells right here. And then the keratin pearl is the most obvious you're going to see on the test. If you ever see something like this on the test, this big keratin material, especially if somebody has risk factors for cancer, I'd be highly suspicious of squamous cell carcinoma. The last thing I'm going to talk about is more of an embryonic or early childhood disorder. It's going to be the Tracheoesophageal Anomalies. So how this works is you have defective formation of your esophagus in utero. There's 3 different subtypes to this. You can get pure esophageal atresia, you can get pure fistula, or you can get a combination of both. And let me show you what that looks like. So if this is our esophagus and this is our trachea, what's going to happen is that you can get a pure atresia, which just means there's just a blind pouch, and there'd be no possible way for you to get food into your stomach this way, because there's no possible connection between your distal esophagus and either your trachea or your proximal esophagus. You can get a pure fistula where both ends of the esophagus actually divert into the trachea and form a fistula. But most common is this esophageal atresia and a fistula. So you pretty much have this blind pouch here, but then in order to get any sort of food into here, your body has formed this fistula from the trachea. So the trachea can actually get food somehow into the stomach, but that's still not good for you, and as we'll see in a second. So how does this present? Well, in utero, you're going to have somebody with polyhydramnios. So polyhydramnios means extra fluid, amniotic fluid. And the reason this is happening is because normally in utero, the baby is able to drink the amniotic fluid and then it pees it back out, right? So you're going to get polyhydramnios because the baby cannot drink any of the fluid in, so it's stuck in the cavity and it grows. In a neonate, you're going to get failure to swallow or vomiting during feeds because there's no easy connection between our oral cavity and our stomach. You can drool, you can choke, and you can also get cyanosis, so you can turn blue because of laryngospasm. And that kind of makes sense, right? If you have all of this acidic, bad, or foody material coming into your trachea, threatening to go into your lungs, your body's going to compensate by constricting that whole area, and you're not going to get as good of lung ventilation, and you're going to have cyanosis. On a chest x-ray, you're going to see 2 things. You can see a gas bubble or air in the stomach because of the trachea's connection, or you're also might see an inability to pass an NG tube into the stomach. And so both of these are accessible in this picture here. We have a big air bubble right here in our stomach, and then an inability to pass an NG tube. If you look at the top of this x-ray, you can see how the NG tube's not passing down like it normally should all the way down in. It's getting kinked up here because there's an atretic proximal esophagus that's preventing it from going all the way down. So that covers the upper esophageal conditions. Let's talk about a few conditions that are associated with hematemesis, or vomiting of blood. So I want you to, when you see vomiting blood on a test, there's not too many things they're going to try to test you on, for step 1 especially. So I want you to subdivide it between painless and painful hematemesis. If you see painless hematemesis, I want you to think bleeding esophageal varices, okay? That's it. There's maybe some other conditions that you could possibly consider, but for now, if you see painless hematemesis on step 1, especially in somebody who has alcohol use disorder, I would highly consider esophageal varices as your one of your strongest answer choices. Now, painful has a few other options. You can get something called Mallory-Weiss Syndrome, you can get Boerhaave Syndrome, or you can get a ruptured peptic ulcer. So we already talked about bleeding esophageal varices earlier in the anatomy section, but I'm just going to go over it as a condition now. So that's the pathogenesis is dilated lower esophageal veins, and it's related to portal hypertension. And these dilated veins, they may rupture and cause really bad bleeding. So again, if this gets big, this can get big. And so we've seen this picture before. If you have portal hypertension, that portal hypertension can push fluid up into your systemic circulation. And because your systemic circulation isn't equipped to handle these kinds of pressures, you can get upper GI bleeding right there. So this will present, it can be asymptomatic bleeding. You could have painless hematemesis, which we just talked about. You could have melena, which is like coffee ground stool, and that's due to digested blood in your bloodstream. You could also get hematochezia, which is bright red blood, and that's usually due to undigested blood in your bloodstream. So if you have a esophageal varix that bursts open and starts flowing very, very quickly down your GI tract, it might not have time to digest, so it might look like bright red blood. And you treat this by surgical banding, and there are several medications you can give, more step 2 relevant than step 1, but still good to know. You can give propranolol, that's usually prophylactically, but in the immediate setting, you can give octreotide. You usually give antibiotic prophylaxis. There's a few other things you should do in this spot. You should give them a PPI. You should type and cross them. You should put in 2 large bore IVs. You should give them blood if they need it. So there's a whole algorithm toward upper GI bleeding that I'm going to cover in the rectum section, actually. But that's just something to keep in mind. And again, here's the picture we saw earlier with the bleeding varix. So for painful hematemesis, let's talk about these 3 steps in real quick. So we have Mallory-Weiss syndrome, and the pathogenesis of Mallory-Weiss is that you have a mucosal tear due to retching or vomiting. And so what does that look like? We've already seen our 4 layers of the GI tract right here: mucosa, submucosa, muscular layer, and serosa. And what's going to happen in Mallory-Weiss is that you're going to have a mucosal tear just in this layer right here. And it's a longitudinal tear. So if you imagine, it's coming in and out of the screen, okay? And so this usually bleeds from the left gastric artery. I've seen that tested once or twice before. And so I'm going to go over the 2 arteries you really need to know in this area that bleed a lot. And so the left gastric artery can bleed, and there's the left gastric. That can bleed in Mallory-Weiss. We'll talk about peptic ulcers as well. It can bleed if you have a gastric ulcer, so that can all cause bleeding. And then just while we're here, I just wanted to let you know that the gastroduodenal artery can bleed profusely if you have a ruptured posterior duodenal ulcer. So if you imagine an ulcer right in this area, that can bleed and cause really, really bad bleeding. The risk factors for Mallory-Weiss, because it's a tear due to prolonged retching or vomiting, it kind of makes sense that the risk factors are going to be people who use alcohol excessively, especially binge drinkers, as well as people who have bulimia nervosa. And the presentation, as we discussed, it's a painful hematemesis. And this can increase your risk of Boerhaave syndrome. So it's a good time to talk about Boerhaave syndrome now. So Boerhaave syndrome is a transmural tear of the esophagus, which means it goes through all 4 layers. Okay, so this was Mallory-Weiss syndrome. In Boerhaave syndrome, instead of just affecting the mucosal layer, we're going through all 4 layers. And this could be very dangerous because this can rupture your esophagus. Another thing you might see is that air from our esophagus can infiltrate into the mediastinum and the associated tissues, the subcutaneous tissues. And so because there's a tear and now there's a pathway between our lumen and our subcutaneous tissues, air can actually flow right through that. And in mnemonic, I like to remember to differentiate Mallory-Weiss and Boerhaave syndrome is that Boerhaave can bore through the entire wall. And so here's some pictures of bores. These things right here, they can dig through, they can make huge tunnels. These are boring drills here. That's how I remember Boerhaave syndrome. And again, this is going to present with painful hematemesis after violent retching. As you can see, it's a very similar presentation as Mallory-Weiss. So you kind of have to work both of them up at the same time. You have to assume it's Boerhaave's, or you have to treat every Mallory-Weiss like it's Boerhaave syndrome just to be safe. But in Boerhaave, in addition to the painful hematemesis, you might actually, on a test question especially, they might mention this, this Rice Krispie feeling, this crepitus on the neck or the chest wall. And that's because air has escaped from the esophageal lumen into the subcutaneous tissues, and you could feel that air underneath the skin. You might also hear this phrase called Hammond's crunch. That's a crunching sound on the cardiac auscultation, and that's because air has entered the mediastinum. And so on how do you diagnose this? I've seen this, if they're going to give you Boerhaave's, they usually give you an x-ray, or they talk about that crepitus, so you know it's not Mallory-Weiss. They're not going to try to trick you in that regard. So on a chest x-ray, you're going to see something called pneumomediastinum, which is air in the mediastinum for the reasons we've already talked about. And right here, you can see that air has already entered the mediastinum and it goes all the way up. So now to diagnose this is definitely not a step 1. This is more of a step 2 concept, but I'm just going to let you know anyways. You can give them a gastrographin or water-soluble contrast esophagram. That helps you see what's actually going on. The one thing they like to test here is they want to make sure that you don't give people barium in this spot, because it can precipitate mediastinitis and kill the patient. And so I just remember the mnemonic. I think of it, I avoid barium unless I want to barium. So just as an idea. And then treatment, you have to surgically correct Boerhaave syndrome because the esophagus is actually ruptured. It's a surgical emergency. And the last one, I'm just going to touch on this because I talk about peptic ulcer disease in the stomach section, but I just want to let you know that the ruptured peptic ulcers can cause bleeding. Here's my chart from the stomach section that you can see, and we've actually already talked about this when we just talked about Mallory-Weiss syndrome. With bleeding ulcers, you can get really bad bleeds and signs of shock, or you can have subacute or very mild bleed. So you can have the whole spectrum of an asymptomatic bleed to somebody presenting to the ER in shock. And so gastric ulcers, they're going to be at the lesser curvature through the left gastric artery. So I already showed you this left gastric artery, the same artery that's affected in Mallory-Weiss syndrome. You can get an ulcer right here that starts bleeding off of that artery. And then posterior duodenal, we talked about the GDA, and that can cause bleeding right there. Now let's move on to lower esophageal sphincter and motility conditions. The first one, and the most high yield of these conditions, is achalasia. Then we'll talk about scleroderma, esophageal dysmotility, and we'll finish it off with a motility problem, the esophageal spasm. So achalasia, what does that actually mean? So chalasia means relaxation of a body cavity. A means no in medical terms, like asymptomatic means no symptoms. So achalasia literally means no relaxation of a body cavity or opening. So they're referring specifically to the lower esophageal sphincter in this case. There's no relaxation of the lower esophageal sphincter, and that's what's going to cause all of our symptoms. So why does this happen? Well, what happens is that our lower esophageal sphincter can't relax because of damage to our myenteric plexus ganglion cells. So now we have to talk about the myenteric plexus really quickly. This is from our GI tract intro lecture when I refer to each of the layers and what they do. As you can see, the myenteric plexus has an important role in regulating sphincter tone in addition to peristaltic contractions. Those are the two things the myenteric plexus does: peristalsis and sphincter tone, okay? So if we look at the myenteric plexus again, you can see that it's just responsible for these two things. And if they're injured, you're going to have both a loss of peristalsis and abnormal tone. From our physiology section a little bit ago, I told you that the myenteric plexus regulates nitric oxide and VIP, and so that can be a problem that we can show you right here. Here's our lower esophageal sphincter, and normally nitric oxide or VIP can come in and relax the lower esophageal sphincter, and life's good. The problem is that this whole pathway is mediated by our myenteric plexus neurons. They're the ones who are secreting these compounds. So if you have a deficiency in these neurons, you're not going to get any of these compounds, and this lower esophageal sphincter is going to remain closed. And what that's going to do is it's going to cause a lot of backflow, like we're going to see. There's two ways this can happen. So how do your myenteric nerve ganglion cells get damaged? The first way is primary achalasia, which means we have no idea, basically. Your cells are dying, but it's all idiopathic, which just means we don't know the cause. Kind of like primary hypertension, we don't know why somebody's hypertensive, whereas secondary hypertension, we know the cause. And so same thing, in secondary achalasia, we know the cause. And that cause is either due to malignancy. You can have a tumor that's invading into the tissues and destroying the myenteric ganglion cells, or something that you've probably learned about on your step 1 studies is Chagas disease or Trypanosoma cruzi. That can also cause, you can get mega esophagus, mega colon, and that's all because the myenteric plexus is getting damaged and you're getting, absence of peristalsis, so food's just sitting in your stomach and in your GI tract and dilating, and that's a form of secondary achalasia in this instance. So this has a very unique presentation, I should say. It's going to be dysphagia of both solids and liquids. Remember that with the cancers we talked about so far, this squamous cell carcinoma, that started with dysphagia to solids and then progressed to liquids. And this one, because your lower esophageal sphincter is closed, it doesn't matter if it's a solid or a liquid. You cannot tolerate either of those. So that's really, really important. They like to show you this barium swallow, where it's going to show you a bird beak sign. And remember, we don't use barium in Boerhaave syndrome because it can cause mediastinitis. I just want you to remember that for the future. So this bird beak sign. So as you can see, maybe I should explain what a barium swallow is first. So what you do is you're going to consume barium, and then you can have x-rays taken of your esophagus so that we can see exactly what's going on, how you're able to swallow the barium, and if it goes to your stomach. And in achalasia, all that barium can't get through that really tight esophageal sphincter, and you're going to get the bird beak sign. So you can see how it's all accumulating right before the LES. And you get this bird beak sign, which you can see at the very bottom right there. Now you can also diagnose this through esophageal manometry, and it's going to show up as high lower esophageal sphincter pressure or tone and absent peristalsis. And so let's see what this looks like. So esophageal manometry, how that works is that you extend a tube from the mouth to the stomach, and then what you can do is you have them swallow, and you can record their muscular contractions at each level of the esophagus. So in achalasia, it's going to be typified by high lower esophageal sphincter pressure, and that makes sense. It can't relax because there's no myenteric plexus neurons anymore to help it relax. So if we look here, this is kind of talking about the LES tone. I drew in the dashed line is what would be considered a normal tone, and in achalasia, you can see the tone is increased. I just also want to point out that you can get absent peristalsis because we also need our myenteric plexus neurons to help out with peristalsis. So in a normal situation, you'll have this part of the esophagus contract and then this part, and so you can have food moving down correctly as they contract in unison. But the problem with achalasia is you have this random or absent peristalsis. So not only does your lower esophageal sphincter not work, you don't have any coordinated peristalsis in the first place. And so the complications of this is that if you have a backup of food, that can push against your esophagus and cause chronic inflammation and irritation. And that can also cause squamous cell carcinoma. So if they're going to test you on achalasia, you always have to think about other differentials, especially with the lower esophageal sphincter. And the most common differential that you're going to encounter is sclerodermal esophageal dysmotility. And so what this does, so first off, scleroderma is an autoimmune condition typified by fibrosis of all your skin, connective tissues, and organs. And how this works is that the lower esophageal sphincter gets replaced by fibrotic tissue, and so it doesn't work as well, and it actually causes decreased tone. And so my mnemonic for this is that I think when I think of scleroderma, I think of scleroderma because it's very low. The tone especially is going to be low because it's replaced by this fibrotic tissue that doesn't work as nicely. So if we go here, if we look at our tone again and we go through what's normal, we have scleroderma or scleroderma with a decreased tone here. And just something to remember with scleroderma, they do like to test this crest syndrome. So if you have somebody who's having dysphagia, usually like in a young woman, just keep a lookout for some of these other phenomena, calcinosis, Raynaud's phenomenon, sclerodactyly, and then telangiectasias. They probably won't give you these specific phrasings. They'll tell you about the hands changing color for Raynaud's. They'll kind of give you a little bit. They'll make you work for it a little bit. But if you see somebody, especially a young woman with dysphagia, make sure to pay attention to some of these other associated symptoms because then it'll make it more likely that they're talking about scleroderma versus achalasia. And the last one I'm going to talk about, not so much a lower esophageal sphincter problem, but just a general motility problem, is esophageal spasm. And so the pathogenesis of this is that you have uncoordinated contractions of the esophagus. And there's nothing wrong with your lower esophageal sphincter, but you just have these weird contractions going on in your esophagus that prevents food from going down in a coordinated pattern. And so how do you diagnose this? The easiest way is through a barium swallow that'll show a corkscrew esophagus. And so you can see right here on the right, you have a corkscrew esophagus that's very twisty and curvy. And on esophageal manometry, you're going to get normal LES sphincter tone, but very, very weird peristalsis. So if this is our normal tone right here at the bottom right, you can see in diffuse esophageal spasm, it's actually pretty normal. It comes back up to baseline like it should. But the peristaltic contractions are very abnormal. They don't have any rhyme or reason. They're not methodical in any way. And how do you treat this? You actually treat this with nitrates and calcium channel blockers to kind of calm those spasms down. So now let's move on to what I think is the most high yield portion of this lecture, especially of the conditions. It's this pathway of GERD, Barrett's esophagus, and adenocarcinoma. So GERD, the pathogenesis involves transient decreases in LES tone. And what that does is it allows acid to get into your esophagus. So it's kind of like the opposite problem we were having in achalasia, where nothing can get through. This one, you have a little bit too much of a decrease in your tone to where acid can get back up into the esophagus. So what that looks like is that normally we have a lot of acid sitting in our stomach, and that acid can try to come back up here. But if we have our lower esophageal sphincter here, when it tries to get into the esophagus, it's going to get denied. But these transient decreases in tone allows the acid to get up there. So there's several risk factors for GERD. One of them is being obese or having a high-fat diet. First off, that can make it to where you have more acid in your system in the first place. But I think the more pertinent physiologic factor with obesity is that you have a lot of excess adipose tissue that can push up and put more pressure on that lower esophageal sphincter to open, and also put more force into the acid onto the LES in the first place. Alcohol, tobacco, and caffeine are also risk factors because they can increase your acid production. Scleroderma is a risk factor for the reason we just talked about, because it has, remember, decreased LES tone in the first place, and our mnemonic for that was scleroderma. And then a hiatal hernia can also be a risk factor. The reason why is because if we look at our lower esophageal sphincter right here, it's in a pretty good place because it has the diaphragm support in a way to where it can't really budge. The problem is when a hiatal hernia, what happens is that a portion of that your stomach gets pushed above the diaphragm. So this portion here kind of goes above the diaphragm. And if your lower esophageal sphincter is already above the diaphragm, it's a lot less stable. It's a lot less strong. It doesn't have the support of the diaphragm anymore to keep it closed either. And so that can already cause lower esophageal sphincter tone, decreased LES tone and more GERD symptoms. So how does GERD present? GERD usually presents as heartburn or chest pain that worsens after meals and at night. And the reason it's at night is because if you lay flat, it's easier for the acid to overcome. There's no gravitational force now limiting the acid from trying to get into your esophagus. They really like this. They like to give you a patient who recently developed asthma as an adult or has this cough as an adult. That's atypical for asthma. So just think about GERD in that presentation. You can also get hoarseness because you're having reflux into your larynx. You can get damaged tooth enamel, and you can get trouble swallowing as well. And on histology, you're going to see some eosinophils, but you're not going to see too many. And I'll talk about that. The reason why I mentioned the some eosinophils is because there's another condition later called eosinophilic esophagitis, where you get a ton of eosinophils. So if you see a few eosinophils, it still may be GERD. Another thing I want you to think about is that all of these symptoms like hoarseness, dysphagia, there's pain involved. It's important to think about whether it's GERD, Barrett's esophagus, or adenocarcinoma. And it's tough to tell the difference from that presentation. And the algorithm can be kind of confusing. So I break it down into a very easy way to realize how to triage GERD, especially on a test. So the first thing I want you to do in anybody who you think may have GERD, you need to evaluate them for alarm symptoms, okay? And what these are, anybody age greater than 50, that's an alarm symptom. If they've had recent weight loss, if they have anemia, hematemesis, dysphagia, or odynophagia, so trouble swallowing or pain while swallowing. All of these, if they have alarm symptoms, they need to get an upper endoscopy first. Okay, you can't just treat them empirically. Those are all risk factors. Any one of those is a risk factor for esophageal cancer, and you don't want to miss that. You can't just treat esophageal cancer with a PPI, right? So if they have alarm symptoms, you should start with the upper endoscopy. If they don't have any of those alarm symptoms, if it sounds like a classic case of GERD, just some chest pain or heartburn that gets worse after meals or at night, and they're in their 30s, then you can start them empirically with a PPI or a H2 blocker. This is from our stomach lecture. I'm going to talk about the mechanism by which our parietal cells can make hydrochloric acid in our stomach. I just want to point out that our PPI and our H2 blocker, the PPI will block. So this whole pathway, just so we know, all it does is, well, one of the things it does is it just produces acid into our stomach lumen, okay? So that's bad if you have GERD. So how do we stop that? PPIs can stop that by inhibiting this enzyme, and H2 blockers can stop it by inhibiting this enzyme. There's several complications of GERD that you need to know. First off, esophagitis, and this should make sense because the esophagus is going to be inflamed by all that acid. You can also get esophageal strictures, Barrett's esophagus, and esophageal adenocarcinoma. So let's talk about esophagitis real quick. You can have the acid in your stomach coming up, and all that acid in your esophagus will cause inflammation, and that's actually the most common cause of esophagitis. For esophageal stricture, which we talked about in the upper esophageal conditions, you can see here that if you have inflammation, you can get fibrosis eventually, and that can cause luminal narrowing. And acid reflux is our most common cause of esophageal stricture, which makes sense because they're both related to esophagitis in the first place. Now, the important one to think about is whether or not this person has Barrett's esophagus. And so before I talk about what Barrett's esophagus is specifically, we need to know what metaplasia means. So metaplasia is a reprogramming of stem cells to replace one tissue type with another. And usually this happens because of repeated cell damage. So if we're going to look at the pathogenesis of Barrett's esophagus, it is a metaplasia of our lower esophagus from our non-keratinized stratified squamous epithelium to non-ciliated columnar epithelium with goblet cells. So remember from earlier in this lecture, we talked about how most of the upper esophagus and parts of the lower esophagus are composed of this stratified squamous epithelium. So what happens in Barrett's is that stratified squamous epithelia turns into this simple columnar epithelia, and that's a form of metaplasia. So you can see here the squamous cell, all these are stratified squamous, and we end up with our simple columnar. Now, I just talked about how this is usually due to repeated cell damage. And so in this case, it's because of the repeated damage from all that gastric acid that's hitting it. And so here's another picture of Barrett's esophagus. You have your stratified squamous on the left, and then you have your simple columnar on the right. And here you can see these goblet cells here can protect us from acid. So basically what's happening is that our lower esophagus is getting damaged repeatedly by this gastric acid. And this stratified squamous epithelia at some point just says, I can't do this. Like, I need help. And so the simple columnar epithelia says, hey, I got you. And they switch. And so the simple columnar epithelia starts to be produced in your lower esophagus to protect from that acid using these goblet cells. And that's all fine and dandy. The problem with that is that if you undergo a process like metaplasia, you increase your risk of cancer because you've already transitioned your stem cells, and these can actually progress to a form of dysplasia and finally cancer. So here's a picture of Barrett's esophagus. You can see a lot of the stratified squamous epithelia here, but there's a big invasion of our simple columnar or pseudostratified simple columnar epithelium that's already formed, and that's because of the damage coming in from the stomach here, damaging the lower end of the esophagus. And just don't forget this pathway. Anytime you see metaplasia, like a reprogramming of our stem cells, that's a huge risk factor, and that can form dysplasia, and finally that can lead to cancer. So now let's talk about esophageal adenocarcinoma, and we'll contrast it. While we do this, we'll contrast it with the squamous cell carcinoma that we talked about in the upper esophagus. So this is a cancer of our glandular epithelia. From our GI intro series, I mentioned that there's several glands throughout our lamina propria. I just want you to know that your embryonic GI tract in general is full of glands. So that's why you're going to see a lot of adenocarcinoma coming up, whether we talk about the esophagus here, or the stomach, or the colon, or the pancreas. All of those generally form adenocarcinoma because that's a type of glandular epithelia instead of squamous cell carcinoma. So now this is the most common esophageal cancer in the US, but the second most common cancer worldwide, second to squamous cell carcinoma. And it's usually located in the lower 1/3 of the esophagus, which should make sense because that's where all this metaplasia is happening because of repeated insults by gastric acid. So let's look at the causes. We know chronic GERD is a big cause, and that's going to form Barrett's esophagus. You can also get esophageal adenocarcinoma from smoking, obesity, and achalasia, because remember that irritation from achalasia doesn't just happen in the proximal esophagus. It's obviously going to affect the distal esophagus too. So this presents like most cancers do with weight loss. You get that progressive dysphagia that we talked about with squamous cell carcinoma because the tumor is starting to grow bigger and bigger and obstructing more and more of the lumen. Again, you get odynophagia because it can invade nerves, and hoarseness for the same reason. And on histology, you're going to get angry glandular tissue. And so what do I mean by that? On the left, these are normal glands, okay? They're doing their thing. They're very well organized. They're very circular. There's only one layer between them. There's not really dark nuclei composing any of these cells. But if you look over here, you can see how thick the tissue is and how dark it is. Whenever you see this very dark nuclei, I want you to at least consider the possibility that you're looking at a cancer. And they'll make it obvious on tests. They don't expect you to be pathologist, but they do want you to know the difference here between a completely normal intestinal gland versus adenocarcinoma. Okay, now that we've talked about that, we're going to finish up this lecture by talking about esophagitis. So esophagitis just means inflammation of the esophagus, and there's several different causes. There's acid reflux, which we've talked about as the most common cause, but you can also get medication-induced esophagitis. You can get autoimmune esophagitis, also known as eosinophilic esophagitis, and then you can get infectious esophagitis through Candida, HSV1, or CMV. So acid reflux, we've talked about this. I just want to make sure we know. GERD comes up, boom, damages the esophagus. most common cause. You can get medication-induced esophagitis, and some of the important medications to know is bisphosphonates. They like to test that that bisphosphonates, like alendronate, which are often used to help strengthen the bones in women with osteoporosis. If you ever look at the package insert on bisphosphonates, it makes it so where you have to take it on an empty stomach and you have to be fully upright and you have to take it before meals, at least 30 minutes. And all of that is because they don't want to make the esophagitis worse while you take it. NSAIDs can cause esophagitis just like they can cause, gastritis and gastric ulcers. So that's something to keep in mind. And there you go. They can also cause renal injury, GI bleeding, and peptic ulcers. Those are the main things you need to know about NSAIDs. And then tetracyclines like doxycycline can cause esophagitis. I was more during I think one of the resources mentioned that. I've never seen that on a test, but it's something to keep in mind. But you should avoid tetracyclines in children due to teeth staining. Just remember that. Okay, so let's talk about autoimmune esophagitis. So eosinophilic esophagitis it's basically a food allergy for your esophagus. So what's going to happen is that you're going to eat food and then you're going to have an inflammatory response because of that allergic reaction, and that can cause luminal narrowing. And this presents with dysphagia, food impaction, and a big thing that how they like to test it. They'll either show you the EGD, which I'll mention in a second, or they're going to mention that nothing's responsive to the PPI or the H2 blocker. And remember, the proton pump inhibitor and the H2 blocker, they're just decreasing the amount of acid that's getting produced. But this isn't an acid problem, right? This is a food allergy. So that would have no effect. So if you look at this on endoscopy, you're going to see rings and linear furrows. And that's going to look like this. If you ever see this kind of like Looney Tunes themed ring, then think eosinophilic esophagitis. On histology, you're going to see many eosinophils. Okay, there's other syndromes, I should say, like GERD and Crohn's disease, that do have some eosinophils. So if you see eosinophils on a slide, I don't want you to automatically assume it's eosinophilic esophagitis because it may just be GERD or Crohn's. But if you see a ton of eosinophils like I see here, I want you to start thinking of this. And so just what does eosinophilic mean? So eosin is a red dye, and an eosinophil is basically a cell that loves consuming red dye. So the cells are going to appear red or pink. And you can see a ton of eosinophils up in this top layer in somebody with eosinophilic esophagitis. The last type of esophagitis I'm going to talk about are the infectious causes. So Candida, HSV1, and CMV. And now when we talk about the risk factors, they're all going to be the same. All three of these types, you really need to be immunocompromised if you're going to have an infection of your esophagus. So you're going to either have HIV, organ transplant, or prolonged inhaled corticosteroid use. So don't forget about that one. So on endoscopy, what you're going to find in Candida, you're going to find these white pseudomembranes, which are made of fibrin and inflammatory exudate. I have seen it labeled as that. So that's why I wrote that down on a test question. It mentioned, on an endoscopy, we see material, a fibrinous material with inflammatory exudate. And so you had to know that was what Candida's pseudomembranes are made of. HSV1 is made of punched out ulcers. And then CMV is made of linear ulcers. And a mnemonic that's really helped me differentiate these, because it's pretty low yield to think about these in general. I always think about how there's always a line at the CMV. And for those of you who aren't in the United States, this is the DMV, the Department of Motor Vehicles, and they're notorious for taking forever to get anything done. So there's always a line there at the DMV. So I remember that. And so let's look at those pictures. So this is our fibrin and inflammatory exudate, also known as a white pseudomembrane. And so that would be Candida, as you can see right there. Here we have many punched out ulcers. That's HSV1. You can see a ton of punched out ulcers. And the last one are linear ulcers, which I've never seen an EGD picture on question bank, but I have seen them describe linear ulcers many times in like in an organ transplant patient, for instance. And so remember our mnemonic. There's always a line at the CMV to help you remember that the linear ones are CMV related. Another way they might test this, instead of endoscopy, they might make you know the histology. And so for Canada, that's going to be yeast cells and pseudohyphae. In HSV1, you're going to see something called Cowdrey bodies, which are eosinophilic inclusion bodies. And then CMV classically has our owl-eye inclusion bodies. So what do all those look like? So here's Candida. You can see pseudohyphae and yeast cells. Here's the pseudohyphae, these long branches, and then you can see the yeast cells right here, the circular cells. Here we have HSV1, which are intranuclear eosinophilic Cowdrey bodies. This has a ton of them. Just labeled a couple of them right there. And then if you ever see this on a test, these two owl eyes, that's pathognomonic for CMV infections, okay? And that should conclude our lecture on the esophagus. So I look forward to seeing you all again. Our next one is going to be on the stomach. Thank you.